Just to start, thank you so much for the kind introduction. It is my pleasure to be here. It's so difficult to follow the wonderful talk by Dr. Holt-Dannerson, but I'll do my best as well to discuss the management of functional neuroendocrine tumors. Just a little bit of a background. Neuroendocrine tumors can be anywhere in the body. And depending on where the neuroendocrine tumor comes from, they can also produce hormones. So as we can see here, we have like different type of neuroendocrine tumors. There is a neuroendocrine tumor of the thyroid that's called medullary cancer that have the capacity to produce calcitonin, and based on the hormones, they can also have different symptoms as well. So the same with lung neuroendocrine tumors. Lung neuroendocrine tumors, they can produce as well cortisol, and that can cause that excess of cortisol can cause Cushing's syndrome. So, but for the purpose of our talk today, we're going to mainly talk about the small intestine neuroendocrine tumors. These tumors can produce serotonin, and this serotonin can cause carcinoid syndrome, and we'll discuss more about that, as well as the pancreas neuroendocrine tumors. Up to 30% of patients with pancreas neuroendocrine tumors may produce hormones as well. Depending on what hormone is produced by the pancreas neuroendocrine tumors, then it's going to be a different symptomatology as well. And there's other ones, adrenal, there's a rare form of neuroendocrine tumors from the adrenal gland that can also produce adrenaline, and based on that, it can also produce a very specific signs and symptoms related to the excess adrenaline. But I think important to recognize that a lot of these neuroendocrine tumors produces hormones. These hormones can cause symptoms, and based on the symptoms may have a different clinical presentation, and there has to be other treatments in order to control as well the hormone excess. Up to 90% of patients with carcinoid syndrome, so when the patient already have the classic symptoms related to carcinoid syndrome, involve the liver, with primary tumors actually localized in the small intestine or the proximal colon. So now let's talk a little bit about what this all means. The neuroendocrine tumors of this small intestine is caused by a very specific type of cells. These cells is called the EC cells or enterochromaffin cells, which is a type of neuroendocrine tumors. Now, these, if we make it bigger, as we can see here, these cells are responsible to convert tryptophan you acquire that from the diet, and there is an enzyme here, it's called tryptophan hydrolysis, and then it's converted to serotonin. And the serotonin, the way we measure the serotonin can either be by plasma 5-HIAA or even by urine 5-HIAA. So as we can see, this is kind of like how these neuroendocrine tumors may produce serotonin, and based on that, we can have very specific symptoms. So what are the effects of elevated serotonin? So we discussed it can cause carcinoid syndrome, but it can also be as well responsible for tumor growth, and we're going to discuss more about that. Now, this is another picture. So we discussed as well that we have the neuroendocrine tumors arising from the small bowel. So this is a neuroendocrine tumor cells. We know that these EC cells are the ones that are going to produce serotonin. So tryptophan, again, is from the diet, and that tryptophan, based on this enzyme, is then converted to serotonin. And then this serotonin, especially when there are tumors that involve the liver, that's when most often we're going to see the symptoms related to serotonin excess. And again, the way we can measure is either by blood or by urine 5-HIAA. Tryptophan, as you may ask, what is tryptophan? Tryptophan is an amino acid needed for normal growth in infants, and sometimes for the maintenance of certain proteins and enzymes and so forth. Now, we discussed also that this excess of serotonin may cause very specific symptoms like flushing, diarrhea, shortness of breath, palpitations, wheezing. But this excess of serotonin over long periods of time can also cause complications. It can also affect the heart, it can affect the heart valve, it can also cause a scar tissue, what we call mesenteric fibrosis, There is a very rare condition called pellagra, which is niacin deficiency. That doesn't happen very often because now with the use of sandostatin lanreotide, that's not something that happens very often. But we can also see some as well, this excess of serotonin in certain conditions can also cause carcinoid crisis. Most common symptoms related to carcinoid syndrome, we discussed diarrhea is one of them as well, very common. It can be quite debilitating and also it can affect the quality of life. We also discussed briefly that this excess of serotonin can also accumulate on the heart valve, and sometimes that's an indication also for patients they have elevated plasma or urine 5-HIAA that once a year or twice a year needs to have an echocardiogram and seen by a cardiologist to make sure that the heart valves are okay. When there is affects the heart valve, that's called carcinoid heart disease, and valve replacement is usually what is indicated. We also have shortness of breath that we discussed. We seen flushing is another one. So we can also see that this excess of hormone can cause different symptoms and complications as well. Some of you have heard about the 5 So basically the 5 is the one that may exacerbate the symptoms of carcinoid syndrome. The 5 stand for epinephrine. That's usually what you sometimes get, with the dentist. Some eatings, and these are the different foods that are high in tryptophan. Like I say, tryptophan is needed in order to convert, for the conversion of serotonin. But that said, it doesn't mean that you need to prevent eating these foods. You can always try, but at the same time, if it's not causing any symptoms, you don't need to avoid this. And I think that's usually the recommendation. They say with alcohol, some patients may have some worsening flushing with alcohol, with a glass of wine. Some others may not. And I don't think that you need to deprive yourself for the things that you enjoy in terms of eating or any other, or exercise or emotion. But that's basically what defines eats, which is epinephrine, eating, motions, ethanol, or exercise. But that's we don't want you to prevent yourself, you can do all these activities and eat all of that. And then you see, so over time you will learn what are the situations that may worsen the flushing. Sometimes I have a patient that enjoys to drink a glass of wine, and sometimes may do like a short-acting sandostatin, and then it can have a glass of wine. I mean, I don't think that we want you to not do all these things. There are things that we can do around it, and of course, always keep an eye on what things may worsen your flushing, so the symptoms related to carcinoid syndrome. We discussed about that, about the different symptoms related to the carcinoid symptoms. We discussed diarrhea, and that's usually considered the most bothersome syndrome related to carcinoid syndrome. As we discussed, it can also interfere with the quality of life, interfere with the daily activities. Usually when we see a patient at my institutions, the fellow, I usually discuss with the fellow in terms of management of patients with carcinoid syndrome and neuroendocrine tumors, what are the interventions that we need to do in order to control the hormone excess, and what are the things that we need to do in order to control the tumor growth. And then we discuss about this excess of serotonin is the cause of these symptoms as well. Carcinoid syndrome diarrhea, as we discussed, the most debilitating symptom related to serotonin, to the excess of serotonin, and occurs in 80% of the patients. And these episodes can vary from a few to even 30 episodes per day. They can be watery, not bloated, they can be explosive, they can be accompanied by abdominal pain. Sometimes we need to be mindful, especially if there are consistent abdominal pain that needs to be evaluated. Sometimes that be related to what we call this mesenteric fibrosis. This excess of serotonin also causes scar tissue around the lymph nodes that are present in the abdomen. And also the diarrhea is not necessarily related to the flushing. So some patients may have more flushing than diarrhea. Some other patients may have more episodes of diarrhea and not necessarily flushing. But I think it's important to recognize all of those symptoms. There is a medication called telotrestat, and as we discussed earlier, we discussed the tryptophan is usually from the diet, and tryptophan is converted to serotonin, so HT serotonin, and then it goes. This serotonin goes into the circulations, and it is metabolized in the liver by this 5-HIAA, and that's what we actually measure either in the blood or in the urine. There is a medication called telotrestat, and this medication blocks the enzymes that convert the tryptophan to serotonin. So what makes sense, if it blocks that conversion, we'll have less levels of serotonin. And this is a study that was done by Dr. Matt Kulke from, at that time was at Dana-Farber, and where there was 2 different doses of telotrestat. So it was a randomized studies, meaning either the patients were getting placebo or they were getting telotrestat in 2 different doses. And they and the authors concluded that the higher dose of telotrestat not only lower the 5-HIAA, but also the episodes of diarrhea were less frequent. So in this medication, the brand name is Hormonal, and it is approved for carcinoid syndrome diarrhea, and that's the only indication that this medication is approved for. But what other medications we have in order to control? Sometimes the injections may not be enough to control the symptoms related to carcinoid syndrome. Sometimes some of the indications is to give the injections, for example, lanreotide every 4 weeks to every 3 weeks. Some of the patients feel like after 2 weeks, the symptoms start worsening of the diarrhea. Sometimes standostatin can be increased. Sometimes we start at 30 milligrams, and then we can start to 40, 50, 60, depending on how patients is presenting with the symptoms. And sometimes Lomotil can be added, but sometimes may not be enough. May not be enough making adjustments on the monthly injection, may not be enough sometimes with Lomotil. Sometimes for patients it's a little harder to get telotrestat, but there is a clinical trial, it's ongoing, and I believe we're moving now to the phase 3 study of paltusotine. Some of other patients may have been on this study. Paltusotine is also another type, what we call a somatostatin agonist, very similar to lanreotide or sandostatin. Is an oral medication, and this is ongoing as well. It's now in phase 3, but the primary objective is to, right now, because it was a phase 2 study, to understand any adverse events, but this is another medication as well to help with the symptoms related to carcinoid syndrome diarrhea. Another complication related to this excess of serotonin is also called carcinoid heart disease. There is really no data that can tell me if you have these levels of serotonin or 5-HIAA, then you need to do echocardiogram and so forth. But usually we see that the levels are twice upper limit of normal. Then we recommend to do an echocardiogram either every 1 year or every 2 years, and then see a cardiologist to also make sure that everything is okay with the heart valve. There is a concept that maybe this medication that we discussed earlier, telotrestat Hormonal, may help as well for the prevention of this carcinoid heart disease, but this is a question that still investigators would like to answer. But just the information that I want you to get from this slide is that we know that this excess of serotonin can affects the heart valve, causing carcinoid heart disease, and usually when that happened, heart valve replacement needs to be done, but there may be other indications of maybe if telotrestat can also help prevent that. And there is a clinical trial that just opened, I believe, like beginning of this year or last year, and is to understand whether telotrestat can prevent or help the treatment of carcinoid heart disease. MD Anderson, I believe, is the center that has the study open, but something that is on the works, and see if this medication, besides controlling the carcinoid syndrome diarrhea, whether that can also help as well with carcinoid heart disease. So just to summarize in terms of the different aspects of this excess serotonin, we discussed about that it can cause diarrhea, and we discussed that for the management of diarrhea, sometimes the monthly injection may not be enough. We discussed that Lomodal sometimes can be added. We also discussed that the Lotristat is a medication that has been approved for the carcinoid syndrome diarrhea. There is an ongoing trials with valsutocin. So there is still a few medications that is in part of our toolbox in order to help the symptoms related to carcinoid syndrome diarrhea. We discussed about carcinoid heart disease, that echocardiogram needs to be done once a year or every 2 years, and then also be evaluated by the cardiologist. We also discussed briefly that sometimes this excess of serotonin can also cause what we call mesenteric fibrosis, and that sometimes, it can be accompanied with abdominal pain. Sometimes surgery may be done in certain patients, but that's something that we need to keep in mind as well. Pellagra is the deficiency of niacin. So, and if, as we discussed earlier, tryptophan is converted to serotonin, but if a tumor is producing a lot of serotonin, so all the tryptophan is going to be converted to serotonin, and it's not going to be enough tryptophan to metabolize vitamin B3 or niacin. But that's usually not as common as it used to be in the past, because now with injections we see it less and less common. But if for some reason we see these niacin replacement is what is indicated. And we discuss certain carcinoid crisis as well, and there are certain interventions that needs to be done as well for this. So in terms of targeting the excess of serotonin, we discussed about it could be either with the injections that we discussed, or the Lotristat is the two approved agents in order to control the symptoms related to serotonin. And it's important to control as well this excess of hormones. Dr. Havdanarsson discussed the different interventions, systemic interventions, but at the same time, excess of hormones, in the symptoms related to excess hormones, we may need to do different interventions besides the systemic interventions that were discussed earlier. We discussed about the different complications related to carcinoid heart disease, as well as the serotonin has an effect on tumor growth, and it's important to control the serotonin exposures as well. So now moving into pancreas neuroendocrine tumors. I mentioned earlier that up to 30% of pancreas neuroendocrine tumors may produce hormones, and depending on what hormones, they may have different symptoms. Dr. Havdanarsson also explained earlier today the importance of understand the presentation, the clinical presentation of all neuroendocrine tumors as well, whether there is localized in the liver or outside the liver, whether it's very low volume or a lot of disease in the body, and also whether grade, with Dr. Havdanarsson described very nicely about the grade. Something that was not discussed is about, and I get a lot of that question, is about whether my neuroendocrine tumor can be familial. Is not very common. Less than 10% of neuroendocrine tumors may be associated with a familial syndrome. Usually the pancreas neuroendocrine tumors are the ones that are associated with the familial syndrome, like MEN1 or neurofibromatosis type 1 or von Hippel-Lindau. So, but it's not very common. Usually we don't know the cause of what is this neuroendocrine tumors is happening, but just 10% may be familial. But that said, there is always other clinical manifestations associated or besides the neuroendocrine tumor that kind of help us guide whether this could be familial. But at the same time, especially for the pancreas neuroendocrine tumors, we need to understand whether they may produce hormones. And these are the different hormones that may be produced by the pancreas neuroendocrine tumors. As you can see, it's very rare. So like I said, more often it's a non-functional, meaning they don't produce hormone. But like I said, up to 30% may produce hormones. Depending on what hormones, then they may have a very different clinical manifestations. Insulinoma, insulin, and we're going to discuss about it more in detail. So just for the sake of time, we're just going to discuss more in detail about the different symptoms associated from this hormone excess. But like I said earlier, it's important to recognize if the tumor is producing excess of hormones, And if that's the situation, there's two things that we need to do. Number one is what are the interventions needed in order to control the hormone excess, and what are the interventions needed in order to control the tumor growth. And with that, insulinoma. So what is an insulinoma? So insulinoma is an neuroendocrine tumor that produces excess of insulin. So whenever you eat, your blood glucose goes high, and then the pancreas secretes this insulin in order to lower the blood glucose. So that's the function of insulin. Now, if you have a tumor that is producing a lot of insulin, that's going to lower the glucose levels, and then you may have symptoms related to hypoglycemia. The symptoms of hypoglycemia can be anywhere from feeling sweaty, feeling dizzy, feeling anxious, blurry vision, headaches, very irritated because you don't have enough of the blood glucose. When that happens, these symptoms of glucose is relieved by having a very high sugar content meals, like for example ice cream or orange juice that have a high content of glucose. And hypoglycemia, what is hypoglycemia? Usually when the glucose levels are less than 50. So, and I think it's important to recognize the symptoms related to hypoglycemia. Usually these insulinomas are, when they start causing symptoms, often they're localized, and sometimes surgery is what is needed, and that can help to control the symptoms, and is usually curative. Sometimes it can be a little bit late as well on the recognize this that this may be caused by the neuroendocrine tumor. Sometimes, in order when the patient is usually initially diagnosed with insulinoma, sometimes we have to do certain interventions in order to control the symptoms related to hypoglycemia, such as using meals that are high on carbohydrates. Sometimes we provide continuous glucose intake as well. There is a medication called diazoxide, and basically that medication reduces the insulin reduction. So as in a patient with insulinoma, we want to help control the excess of symptoms because of the excess of insulin. Diazoxide can certainly help as well, because what diazoxide is doing is basically block the release of insulin, and with that it can help not to have a lot of insulin that may cause the hypoglycemia. Similarly, octreotide and lanreotide can also help as well to control the symptoms related to hypoglycemia, because what this medication is doing is prevent insulin secretion as well from the pancreas. That can also help. In patients that have metastatic disease related to insulinoma, there are other interventions that could be recommended. Surgery, we discuss a little bit about later, and Dr. Havlanarsson discuss about that, and Dr. Tanaz will discuss later today about when to do surgery in patients with neuroendocrine tumors, and there are systemic therapies as well that can be help to control tumor growth or shrink tumors, and with that, I can also release the excess of insulin and help with the symptoms as well. Gastrinoma, that's also very rare. Usually when we have a patient that have a gastrinoma, we need to make sure that we test the patient for MEN1. Up to 30% of patients with gastrinoma being associated with MEN1. And what is gastrinoma? It's a neuroendocrine tumor that produces excess of gastrin. And what gastrin is doing is stimulates the cells within the lining of the stomach. This is called the parietal cells that causes production of acid as well in the stomach. So you can understand if you have a gastrinoma that's going to cause a lot of acid, and this excess of acids can have a series of complications, peptic ulcer disease, including sometimes perforation, bleeding, and some of the symptoms associated with gastrin is also diarrhea, heartburn, as well as weight loss. Important that if a patient has this gastrinoma, the intervention that is needed is to also give a high doses of what we call proton pump inhibitors. It can either be omeprazole, pantoprazole, sometimes twice a day, but it's high doses. It's not your regular doses that is given for a regular heartburn. This is a high doses of these medications. Now, if we have a patient that have more advanced disease or metastatic, the similar interventions with the monthly injections can also help because it inhibit the excess of gastrin, as well as surgery or other liver-directed therapies like ablation embolization. Maybe Dr. Tanaz will discuss that later today, and as well systemic therapy. Systemic therapy, the function is to slow the growth of tumors, and maybe shrink the tumors in certain situations, and with that, I can also help decrease the production or excess of these hormones. VIP-oma, so it's very rare. So these are, I'm just talking, the last two are very rare conditions of pancreas neuroendocrine tumors that produces excess of these hormones. So VIP-oma stands for vasoactive intestinal polypeptide. These hormones is responsible to help with the electrolytes in your body, as well with the circulation of water as well in the body. And when you have this excess of hormone, what is going to cause is excessive watery diarrhea, and with that, you're going to have low levels of chloride as well as low level of potassium. So it is important in those situations when we have this to replete fluids and electrolytes, because the patients that have a VIP-oma lose a lot of electrolytes, but as well we need to also provide other interventions such as the monthly injections. Sometimes the steroids can help with this as well, but it's important to recognize if a surgery can be done. I think that's something that can certainly help in patients with excess of these hormones, and if we are able to do these interventions, then it can help also the symptoms. If the patient has advanced more metastatic disease, there are other certain interventions. We discussed here about the injections and surgery. Dr. Tanaz will discuss about the importance of surgery, how much is the indication of surgeries, where there is how much is the volume, where there's 75% of everything, 80. So Dr. Tanaz will discuss that, and as we discussed earlier, always systemic therapies is needed. And I'm almost done. Wow. So, yeah, and then glucagonoma, very, very, very rare. So glucagon is also help utilize glucose, and basically what glucagon is doing is trying to extract a lot of glucose into the circulation. So patients that have this excess of glucagon can have diabetes. Glucagon is also responsible as well to help the metabolism of amino acids. So in those situations, if we have this excess of glucagons, and we need to give nutritional support, manage the diabetes, infusion of amino acids as well. And we can see this is a very specific rash. It's called necrolytic migratory erythema. So it's a long name, but it's a very specific rash, a scaly rash that can be associated with glucagonoma. So sometimes if we have this evidence of rash, and then we have weight loss, we have diabetes, sometimes we can suspect of glucagonoma, which is a neuroendocrine tumor that produces excess of glucagon. So metastatinoma is very rare. These are very rare. So usually what I want you to take from this is that there are specific symptoms related to its excess of hormones that help us suspect which tumor or which neuroendocrine tumors may be. Like this excess of somatostatin also inhibit the release of insulin. So if there is not enough insulin, your blood glucose is going to go high. It can also cause diarrhea as well, because it inhibit also some what we call pancreatic juices as well. And with that, you can have these symptoms as well. Like surgery, like I said, Dr. Tanaz will discuss later today about the indication of surgery, but surgery help a lot of the symptoms because you remove the excess of tumors, or when it's localized, you can also remove it as well, or resect it, and that can help the symptoms as well, but there is other interventions too. I just want to give a couple of words on thoracic neuroendocrine tumors, because I think it's important as well to recognize that some of these lung neuroendocrine tumors can also produce excess of hormones. So up to 50 or 60% of patients with lung neuroendocrine tumors may produce hormones, and usually it can either be serotonin, as we discussed earlier as well. Serotonin can also cause this serotonin from the lung associated with carcinoid syndrome, but they can also produce excess of a hormone called ACTH. And this ACTH, what it does, ACTH is from the pituitary gland, which is in the brain. So you kind of have an imaginary line is between your eyes, and exactly in the middle, that's where your pituitary gland sits, and that is the mother of all hormones. So that's where ACTH is produced, and ACTH sends a signal to the adrenal gland. The adrenal glands are on top of the kidney, and the adrenal glands, if you cut it in half, it has two layers. One is the outer layer that produces different hormones. One of them is cortisol. And if you have this excess of ACTH that comes from the lunge neuroendocrine tumor, then it stimulates the adrenal gland to produce a lot of cortisol, and that's what we call Cushing's syndrome. These are the different symptoms associated with Cushing's syndrome, and there are different interventions as well to control the excess of cortisol. So Dr. Havdanarsson discussed the different therapies as well, as we discussed for these neuroendocrine tumors that produces excess of hormones. We need to understand what hormone it is. They can cause different symptoms, and then there may be certain interventions as well. But there are also these different systemic therapies that was discussed earlier by Dr. Havdanarsson that not only help control the tumor growth, but with that can also control the excess of hormones. And then this is my summary, and the slides will be provided to you of the different symptoms. I just wanted to let you know that the NIH, we have a big interest and research in neuroendocrine tumors. We have natural history study that allow us to follow patients over time. Right now we have 4 treatment studies for neuroendocrine tumors, and we are going to have an alpha PRRT coming up soon. We have a very comprehensive team to help us see pediatrics and adult patients with neuroendocrine tumors. And with that, this is my information and my contact information. You have any questions? Thank you.